It's exciting to be here in front of this illustrious audience, and Dr. Powell, who is the editor of two prominent AACR journals, and our distinguished panel. I'm a breast cancer researcher in Marin County, California, which I think many of you know has a history of a very high incidence of breast cancer. This study was conducted in 1997 to 1999, when the incidence was 199 per 100,000. That has subsequently decreased to 156 per 100,000 in the typical white non-Hispanic population in Marin County. So that study, originally done in 1997 to 1999, showed very few differences between cases with breast cancer and the controls. They were very well matched in age and ethnicity. And the big question was, why is there no difference according to the classic Gale model risk factors? So we felt we needed a better test. And the hypothesis was that in a high-risk Marin County population, the OncoView algorithm, which integrates both genetic variation and personal risk factors, as seen in the Gale model, will exhibit improved ability to accurately identify women at elevated risk. The genetic polymorphisms, the SNPs that we studied, were small inherited differences that are basis of individuality and influence disease risk. We had 22 of these and 19 genes. The classic Gale model risk factors that we incorporated in this model were age at first menses, age at first live birth, number of first-degree relatives with breast cancer, number of breast biopsies, and the result of that breast biopsy, whether or not there was atypical hyperplasia, for example. The other classical risk factors that we also studied were hormone replacement therapy, age at first living in Marin County, or total years of living in Marin County. Because there was a question, are there environmental factors in Marin County that are important? For example, serpentine is the state rock of California. It has a lot of heavy metals in it. Or is there something in the water, or in the air, or in the dry cleaning fluid? But we didn't find any differences. So when we incorporated the 22 SNPs, what we wanted to look at statistically was a positive likelihood ratio of which we defined as the elevated risk cases divided by all cases divided by the elevated risk in controls divided by all controls. In order to estimate risk, we took the SEER average risk for ages 30 to 69, which was the population age group in our study, and that SEER average risk group was 8%. We decided to define elevated risk as 1.5 times 8%, or 12%, and then to look at the fold improvement of OncoView compared to the Gale model and look at statistical significance. So when we compare the Gale model to the fold improvement, which was 2.4 for the OncoView model, it was very significant. It had a p-value of 0.036. And then looking at this another way, the number of additional cases who were at elevated risk were 19 cases. This was a 51% increase in estimation of elevated risk. These are some of the SNPs that we studied. As I said, they're mostly related to steroid hormone metabolism, DNA repair, cell division and death, growth factors, detoxification, and BRCA interaction. And they're also age-related. Some of these SNPs are elevated in a younger population, and some of these SNP effects are elevated in an older population. In conclusion, our theory that the high-risk Marin County population would show an increased risk with using the OncoView algorithm over the Gale model was correct. There was a 2.4 times improvement by incorporating genetic factors with the classical Gale risk factors. This is important for further clinical prevention trials because you want to accurately assess risk before you put patients in a trial. And it's also being used clinically, for example, at Cedars-Sinai Hospital in Los Angeles by a doctor and geneticist, Oro Clark, right now, who's using OncoView, along with her other BRCA tests, etc. Thank you very much.